I was pretty adamant about early on was that, the plan evaluation process has to be a collaborative effort between a physician and the physicist, meaning not even the dosimetrist. And the reason why I felt very strongly about that was that dosimetrists are very good, but they may not know all of the technical nuances or the physics of proton interaction in a particular patient, or anticipate all of the things that potentially can go wrong. So an experienced physicist sitting down with the physician and explaining to them what are some of the technical limitations, or what are the potential uncertainty in the plan would be based on the information that they get from the physician in terms of the clinical disposition of the patient. So it's very important that we do that. And to help that, we developed these dosimetry checklists. I know it is a little hard to read, but the idea over here was, what are the different things what we're going to be doing, the contours, and what is our basically the dosages, the constraints, and then doing an in-depth analysis of the plan in terms of whether we were able to achieve what we wanted, and the minor deviations, major deviations, and putting those on the piece of paper. And if it is within a criteria of acceptability that we have set up, and that wasn't really just sufficient, but having a discussion, okay, if it is 7%, if it's just less than 10% of the criteria that we have set, what could be the standard deviation on that with within two confidence intervals? Have that discussion, and ask the physician what is going to be happening to that patient. So that was the intent, and unfortunately, in a busy clinics, people deviate from that, and it's something I think that needs to be impressed upon.